Okay, from this to the reports from the workshops. And why not starting exactly with the workshop about physical exercise? Woo! The best group, they think. And here to present, whoa, God, is very oh, sorry, I got totally out of control from this dancing thing. Implementing physical exercise in cancer care, presented by Dr. Ingrid Demmelmeier. Welcome.
Yeah, hi, I'm Ingrid. I'm a physical therapist and a researcher at Uppsala University. And I have, together with Birgitta Johansson, organized this presentation on implementing physical exercise in cancer care. And I will stand like this. It was a very active and hard-working workshop group, lots of people involved. And we tried to summarize 5 of the solutions that 5 of the ideas that we came up with. And the first one, which was very obvious, was about increasing and dissemination knowledge on all levels. And it's not just about why patients should perform physical activity, but also how it works and how you can do it. And on all levels there we think about patients, of course, but also healthcare and relatives and politicians, policymakers, and so on. And about that idea, who should be involved, it's obviously healthcare, but also researchers, and we think about educational programs for healthcare professionals on basic levels to get it in there from the start. And who can initiate? We said it was healthcare, government, researchers, and also patient associations can initiate the first steps. And our second idea was about if we want to make this happen, we have to influence policymakers and start knocking doors, meeting face to face, introducing the idea about the importance of this health behavior. And we thought that patients could be have to be involved, healthcare and researchers, among others. And the same groups should initiate this. And then we had this idea that we had from one of our inspirational speakers, and we talked about that was just start in a small scale, just start doing something, start with a walking group or something that you can do in a cheap and easy way, and then get it going, because you can't just sit and wait for the big money to come in. So start in a small scale. And that should involve both patients, public gyms, patients, healthcare, and researchers. And the same groups can initiate it. Yeah, and I'm reading on the wrong line. But public gyms and other actors outside healthcare should be involved there as well. And then we had this idea about the need for teamwork and communication, both within healthcare, but also with actors outside healthcare, NGOs, and public gyms and so on. And patients, public gyms and actors within and outside healthcare should be involved, and they can initiate it. And then we all agreed on that depending on the context and the individual patient, you have to individualize this physical exercise. It can be anything from walking for a person who is not used to exercising too much, and it can be just going on with your usual exercise. It can be anything, so you have to individualize it according to a lot of variables. And of course, healthcare, patients, public gyms, and actors should be involved there. And then if we look at the next slide, please. We sort of summed up this. We didn't separate the ideas because we thought the whole idea is to implement physical exercise. So we started asking the question about how can this contribute to more efficient cancer care? Well, it's about if we manage to implement physical exercise, it will contribute by improving treatment efficacy, cancer outcomes, and quality of life, to mention some important areas. And how can this contribute to more equal cancer care? Well, we started thinking that this is a very cheap and low-tech thing that you can do, and it should be adapted to the local situation again and to the individual patient. But it's something that you don't have to have so much money to do. And less symptom burden, improved participation in social life, and also improvement of the economic situation for the patient if it can actually make you function in a better way and work as usual, or getting back to work earlier. And about health decision, well, this is a health decision. And it's important that it appeals to the healthy sides of patients. And it's something that they can do for themselves without being dependent on someone else, so they can start being active and sort of grow more self-efficient in this aspect. Yeah, that's it.
Thank you very much.
Thank you.
The next group is workshop E, towards useful biomarkers for cancer care and to prevent. This is Tobias Sjöblom. You're alone. I thought you were two of you. It's enough, you're enough. Very welcome.
Thank you. So this was a very productive workshop, I think, concerning how we should bring more useful cancer biomarkers forward to aid the cancer care. One thing that at least I had not appreciated when I came was the need to incentivize the development of predictive biomarkers in industry, because today those incentives are absent. We think that this has to involve the payers, authorities, and also this has to be driven by the pharma, but also by patient advocacy groups and the founders. Another key point was that to increase success in biomarker discovery and development, both academia and also biotech companies need to interact more closely with the regulators. And this is actually for free, and the regulators are very sort of eager to interact. So the initiation is clearly on academia and biotech who develop biomarkers. But there's also a need for clear guidelines for what a biomarker performance, what is an acceptable biomarker performance. And this, we think that the regulators can actually contribute here. And also to define guidelines that enable better studies in academia, aiming to develop biomarkers. And we think that the founding agencies, for example, can help set better standards for the kind of research that they fund. Finally, there was a lot of discussion about how to prioritize which tumor types need different types of biomarkers the most. And one thought is that there is a need for a mechanism to prioritize or make these needs more clear, involving academia, payers, and regulators. And we think that this is something that can be initiated actually by academia or by also driven by patient advocacy groups. We can move to the next slide, please. So to try to sum this up in this matrix, we think that if we can incentivize predictive biomarker discovery, more patients will get the right drug. This means that resource allocation gets more efficient in healthcare. There will be also less side effects and more effect for the patients. And it also helps patients and their kin to make informed choices of care and caregivers, depending on the information about their tumor. A need for clear guidelines for biomarker performance. We think this can contribute by yielding more accurate and more useful biomarkers that will help more informed clinical decisions. Again, prioritized development by need can help in these conditions that currently lack biomarkers. For example, those that are currently discovered or diagnosed too late. This can help resource reallocation to those that need care the most. But it can also help in the development of less invasive diagnostics and, again, prioritize biomarkers for early discovery. So that's sort of a rundown of what we have achieved collectively.
Thank you very much. Excellent. We continue to workshop F, using data for better cancer treatment, presented by Dr. Christian Grunlo. Welcome.
I have to watch. I don't see it here. I have to watch myself. Yes. Hello, my name is Christiane Grünloh, and I'm presenting the results of the workshop on using data for better treatment and diagnosis of cancer. So what we did in our workshop is develop together with the delegates visions of the future. How is life in 2050 from different perspectives? So first of all, if we say using data, what kind of data are we talking about? And as we heard from our inspirational speaker, today or in 2050, the data that we have today may be a little bit different from that what we can collect and analyze in 2050. So on the left side, you see the circle of knowledge, where all the people that are involved, patients, researchers, the nurse, the physicians, are the ones who can provide or collect the data. It was envisioned by the delegates that by 2015 we will have much more ways of collect data. There was some kind of bracelet that they envisioned, or something in the bloodstream that collects data automatically at that non-invasive or even a little bit more minimal invasive procedures could be taken at home. So by technology and by sensors, so that you didn't have to go to the hospital, for example, to draw blood samples. So all this data is collected, and in 2015, we can celebrate already today, there will be no interoperability issues. So all systems in 2050 will talk to each other, no problem. So given that as a vision, the idea is, okay, we thirst for knowledge, but we drown in data. What do we do with that? And on several tables, AI came to the rescue. So with all the data that is collected, and we have artificial intelligence that helps us make sense of what is there and provides the analysis at the right point in time. Next slide, please. So with all the technology, and given that we also had a clear focus on patients, what would that mean? So it would be possible that you have care at home, that you wouldn't have to go to the doctor's office all the time or to the hospital, and that you also have the option that you can get treatment from the expert physicians, for example, in Nigeria. So telemedicine is much more advanced, and we can have expert care from physicians from all over the world. There's, of course, a downside to everything. So with all this data collection, what would that mean to privacy and security? And of course, patients own their data, so they have to give consent. And the concept has been brought up, some kind of dynamic consent. So maybe what is okay today may not be okay tomorrow to share with others, and the other way around. So what actions are needed to get to this vision of the future? Interoperability is not there yet, so we have to solve that. But also legal issues. developing standards so that it's possible, and also balancing this idea of saving that much amount of data and making systems having access to that by still preserving some kind of privacy and security. Thank you very much.
Thank you very much. From this, we go to workshop H, the last workshop for today. Cancer drug repositioning, presented by Professor Peter Nygren. Welcome.
Thank you. It's late Friday afternoon, so I will be very brief about this. Our workshop was also very fruitful, a lot of interesting discussions, and I think that we have to provide first a definition of what drug repositioning is. It is to take one drug that is already in use, very much experience on tolerance and effects in other areas, and to use it for another indication, in this case then the cancer area. And the overall conclusion from our workshop is that this seems to be a highly promising approach for improvement of drug therapy in cancer, both to provide more and efficient drugs and also at probably considerably lower prices. And this approach is actually already in quite much use when it comes to treatment of children with cancer. But there's need to accumulate more evidence behind that approach, so to perform better clinical trials. And one way to do that would be to do trials based on the registers that are already there. That could be a way to make the clinical trials much simpler and thus less expensive. This area will probably not have a lot of funding, so we have to find ways to make the clinical trials more efficient and simpler. Who can take the lead in this? Well, we think that NGOs, governments and patient organizations will have a key role here, but also actually that some companies might be interested in this kind of strategy for drug development in cancer. Off-label use of repurposing candidates. We would like to see that kind of approach, that it is allowed for me as a clinical oncologist to do that. I am not able to do that today, but if I have some kind of scientific rationale, it would be reasonable that I could do that approach in single patients. But in that case, it is of course important to collect and report the data and the observations that I make, for example, within the registers already available. And finally, one interesting way to actually identify candidate drugs for repurposing is to go through reports on adverse effects. That could provide then a rationale or a background to go further on to look for drugs that could be putting in a position for repositioning. Thank you.